There we go. Welcome to Between Two Teeth. We are so happy to have you here. I am Dr. Bob McNeil. This is my...
I'm important, okay? I'm important. I've said it 5 times.
You're important.
I'm Dr. Stephanie Ganner. I'm the periodontist in the practice. And like Bob's kind of talked to you about, this is Between Two Teeth. We're your hosts. And what are we going to talk about today?
Today, we're going to talk about throat screens, how to prevent aspiration.
Oh, good gauze, man.
Good gauze. That was actually pretty good. I liked that. And because, it's an important discussion, it's something that I think a lot of us are not incredibly mindful about.
I'm going to level with you. I hate the gauze pack. I know it's a necessary evil. It's something that gets in my way. It's in the way of my handpiece. It's in the way of my surgical. It's just everything. Gauze gets in the way. But why are we talking about it?
It does, and part of why we're talking about this.
Why is it good?
I hate to bring this up, but I'm on the state dental board.
Do you though? Do you really?
Not really. And we end up seeing problems with aspirations not infrequently. And I've had colleagues who are surgical colleagues. I've had prosthodontists. I've had a bunch of different people, implant parts and pieces, anything that is small and it's easy to get aspirated or swallowed. Even had a new grad have a burr come out of the high-speed handpiece and swallowed / potentially aspirated by the patient.
I mean, let's just back that up. You had a burr come out of the high-speed handpiece and then the patient swallowed it.
Yes, ma'am.
Oh my gosh.
And you obviously haven't been practicing for a long period of time.
I'm just trying to figure out, was that burr spinning at what RPM when it came out? Or
so spinning, and if
was the swallow the worst of the problems?
So if it's not in all the way, all the way, then it can become dislodged. If you're putting too much pressure. When I first started in practice with my electrical surgical handpieces, I was putting too much pressure on the drill and was not letting the burr effectively cut and get appropriately irrigated. And that can happen on the surgical side, that can happen on the restorative side, and it can be really, really tricky. All I'm saying is having appropriate throat screens in there. If you're doing an endodontic procedure, no one likes rubber dams. Rubber dams is pretty much the standard of care with respect to what endodontists would say is needed. Some people use isolites, I believe, is the other thing. Whatever you need to have something to protect that airway, because it's not a problem you want to have.
I couldn't agree with you more. And I know we've all had our horror stories there of something kind of dropping. I was at a Texas Mission of Mercy event, and actually this is my scariest one. And we had a group of dental students around the chair. Of course, the stories are never your fault, right? And this is a big old patient. The tongue was everywhere in the mouth. Dental students taking out the tooth slips from the forceps. No one can see it. So one of the things that I've learned through practicing together is a quick turn to the side can actually kind of save you a little bit, because even the best placed throat screens or gauze, it shifts and moves, and once the patient feels something, they might want to have a swallow reflex there.
And here's what I would also say when it comes to extracting teeth: anytime you can get your hands in there to help protect the area, I can't think of a time I'm gonna push
back a little bit on you here. When I am teaching, especially dental students, extractions, one of the things I know with the hands in place. However, it's kind of a tough thing. If you're learning how to take out a tooth, those forceps are slipping. You might get an elevator that gets errant.
So
your fingers are kind of your livelihood.
And I'll pause you there. That's why you need, if I could put down the tooth, I could demonstrate.
Not at all.
If you get your fingers in there and you've got a forceps and your fingers are actually helping to support, the maxilla, for instance, they're helping to support your instrument. If you go in with an elevator or luxator, you don't want to have slippage there. Having your fingers right in that area it helps give you this, I don't know if you've ever heard of it, controlled force. That's so figuring out and watching people. And if you do get an opportunity to see other practitioners do something, certainly seeing what they do and taking note of that to see if that works in your practice.
I love it. And, personally, I did pick that up from you in practice. And whenever I am, counseling people on, hey, how to take out teeth, I always have my fingers in there. However, I've also seen elevators slip. And it's just one of those things. I love the technique. I support it.
Let's segue to this. What do you do when it does happen? Say you didn't have a throat screen and
right
behind the throat screen.
And so that gets me back to my Texas Missions of Mercy, that bad incident where the tooth slips out of the forceps. We can't find it. I do an immediate head tilt to the left or the right, whichever side I'm on. I'm the right-handed operator, so usually I tilt all the way to the right. That way the patient knows, wait. And I tell the patient, don't swallow, nothing. And I get in there with my hands, an elevator, mirror, something. I try to find that too.
And I'm going to pause you there. You don't want it, just like the old finger sweep thing. You don't want to push it back. You want to be able to visualize it. You want to lean the patient forward. Now it's disappeared. We don't know where it is. You can't see it in the surgical field. You're checking the filter traps. That's what I advise that one new dentist say. Look at your if the burr is there. If you can't find it, the standard of care is you have to recommend x-rays, a chest x-ray, a abdominal x-ray to look for that.
And let's go a little bit further. Why do we get a chest x-ray? Why do we get an abdominal x-ray? What are we?
You have a hard time with the word abdominal.
Abominable. Abominable.
Of course, you want to see if it's in the lungs. If it's not in the lungs,
so what happens if it's in the lungs?
In the GI
just
tract.
So we kind of understand what the full extent of the consequences are.
Gotcha. So if it's in the lungs, that's evaluated. They're going to need retrieval of that item.
Can you just retrieve something out of the lungs, doctor?
Well, I can't, but people can. And so
how is that retrieval process? How does that go?
So you go to the operating room and they go in with little instrumentation and they pull it out. Let's not diverge on that. But what I would say is it's got to come out, or if it's not in the lungs and it's in the GI tract, now if you have some sharp little burr or something, you have to follow that through. And easiest way is with x-rays, of course.
And I'm sure
the other way is tricky.
I'm sure you go get some eyes on that.
But that's sort of the standard, and it puts you in a predicament. All of this to circle back around and say, really, you want to use a throat screen. You're trying in any kind of little abutments into implants. You're using little tiny screwdrivers for implant systems. You've got to tie floss on those things. Once again, from a state board perspective, from a malpractice perspective, someone swallows a little screwdriver.
Oh yeah,
that's a big problem. Use a throat screen. I know it's tough. Using a sweetheart retractor sometimes on top of the throat screen can be a good thing to utilize.
And personally, that's what I do, and that's helped me out a ton. And it's just an added layer if the patient will tolerate all of that.
And some of the suction devices now. I know we've started using that in the past couple of years. A suction device that has something to retract the tongue, and it sort of allows that throat screen to be better utilized.
And as we kind of wrap up here, Doc, and I how do you manage someone with a strong gag reflex who refuses? They're literally pulling the gauze out, putting on the tray. They refuse to have it in there. What do you tell them?
That makes it difficult. There, I may give additional local anesthesia. I may end up doing a greater palatine injection, for instance, to make sure they are profoundly numb in the palate, in the lateral throat area. It may make me change and say, okay, let's go ahead and do sedation, or some relaxation breathing techniques are pretty helpful with that too.
And I hope on a different episode, we can kind of get into more of those relaxation and breathing techniques. Personally, that has changed the way I practice, is how I communicate with the patient. However, that is not the scope of this podcast in particular. We want to make sure we impress upon you the importance of throat packs. Use them. They will save you at some point, if not every day. And it's also important that you train your lead assistant or whoever's in there assisting you on how to place these things. I know whenever I'm training a new staff member, they're not always placed appropriately, especially if you're kind of in a hurry.
And it's your responsibility as the doctor.
Absolutely.
And that's our pause button. If the throat
doctor.
screen's in there and there is an opening spot to the airway, that's a pause, that's a stop, that's a let's change the throat pack, let's redirect it. So thank you once again. If you like what we're talking about, we'd love you to subscribe to Between Two Teeth. If you have anything you want us to talk about, make a comment in the comment section and we'll see what we can do to help you out.
Thanks, guys. This is Bob. This is Steph. We appreciate you tuning in to Between Two Teeth. Appreciate it.